Who's going to be talking to us about what we can do with the microbiome. Thank you.
Microbiome. Yeah. Amazing. And just keep recording.
Thank you very much, and I'm Sunny, and I'm very pleased to be here, and I'm very delighted and honored to be invited by the organizer to talk on this topic. I'm not an infectious disease or microbiologist. I'm a gastroenterologist, probably uncommon here, but I do work on microbiome that, of course, is very closely related to microbes. So, the title of today's talk is on antibiotic alternative. I would talk more on microbiome, but also touch on a few of some other approaches. Of course, when we talk about alternative, we talk about antimicrobial resistance, and this is something, of course, very familiar to this audience here. And we know that it is one of the top 10 global threats, and there are millions of deaths that's associated with AMR in the past few years. And we see that there is a problem with some of these bacteria, and essentially there's no time to wait. And antibiotic alternative, of course, present an important role and alternative and way out of these important global threats. These are the toll of the AMR that you're looking at. So this is probably not an unfamiliar slide that you will see that the toll of antimicrobial resistance is huge, and it is especially relevant in certain parts of the world. In the left, you can see that the toll of AMR that is associated and also directly attributable to resistance. You can see that this is important more in certain part of the world. In the green are the African population, especially in this sub-Sahara Western population. You can see that it is taking a great toll. And when you look at the resistant bacteria, so these are important bugs that we are looking at: E. coli, Streptococcus, and Staphylococcus capsulosis. So some of the well-known resistant bacteria that you would know. And of course, it is also not only about the present situation. If we extrapolate, there has been estimated that it will be taking a larger and larger burden on our population. If we look at AMR, currently it is about 1 million directly attributable deaths, but it is expected to extrapolate to up to 10 million in a few decades. And importantly, on the right, you can see that this part of the world, Asia and also Africa, is taking a large part of this burden. So we know that we got to find a way out. We try to reduce the resistance, and as mentioned by Sally Davis in the UK and also the National Academy of Medicine here, that you can see that we need different approaches to tackle antimicrobial resistance. On the left, you can see that the developing alternative approaches are important. It's critical to the fight of antimicrobial resistance, and vaccine, of course, is an important tool. And on the right, you can see that apart from vaccines, there are other approaches that can be considered and implemented. And for these alternatives, so these are the things that we are talking about. So if we read different paper, or if we read different media, you can see that they include different things. So we are trying to look for something more comprehensive, and some might tell you that there are more than 10 different approaches. Some approach may be a lot more remote or still in very upstream stage. So these are a few things that we are talking about, and I'll tell you a bit more in the next slide, but these are common things that are close or already in place. So for example, vaccination, we know that this is important because it reduces the infection in the first place, and also it helps antimicrobial resistance as well. We have bacteriophage, so phage therapy is getting very important and is close to translation as well. There are some other approaches, so for example, antivirulence factor, antimicrobial peptides, and on here with microbiome, that shows probiotic food here, but I think related to probiotics are the microbiome, both in a GI tract, but also other parts of our body. So these includes, of course, not only probiotics. Related to that, we have what we call prebiotics. So these are actually carbohydrates or fermentable food, actually that feeds the bacteria to promote or modulate the microbiome. We have something called postbiotics. So these are chemicals or metabolites that are secreted by the microbiome. So these are probiotic and postbiotics are related to the microbiome modulation in a sense. We have what we call live biotherapeutic products, which are actually the probiotics, but kind of in a next generation, so they could be newer probiotics, they can be a different strain, they can be engineered as well. And of course, we must have heard about fecal transplant, so this is one approach that we modified the microbiome. So these are a few related approaches where we can modulate the gut microbiome, and in this case, for antimicrobial resistance. And of course, there are other chemicals as well. So for example, we look at the literature, I found this paper. This is not so new now, so it's about 5-6 years, but I think this has done a really comprehensive on what is out there in the landscape. So they classify them into tier 1 and tier 2. So these are what they describe as closer or more realistic approaches that we have. Tier 1 are closer to clinical application or already in translational pipeline, or at least some in clinical trials. So these are antibodies, probiotics, and at that time they didn't mention the microbiome. It was still a bit new, but it's certainly up there as well, and it's related to probiotics. Lysins, which are the chemicals or enzymes that lyses bacteria, vaccines. We have bacteriophages of different kinds, and also antimicrobial peptides, antivirulence factor. On the right are additional therapies or strategies that they consider as a bit premature. So you can see 9 of them, and these are relatively not so developed, so still probably more upstream, as you can see. And of course, this is about 5 years ago, although it is a very comprehensive review. And then we also have reviews looking at some of these pipelines. So antibacterial on here. So on the left are the conventional directly acting small molecules. So they are new antibiotics. And on the right are the alternative approaches. So you can see that there are 6 other groups, but if I point you to the most common ones, so for example, they look at over 400 preclinical projects, so they can classify them into these several groups. So for example, antibodies and vaccines are important, so 14%, followed by phage and also microbiota. So these are 2 areas that we'll focus a bit more on. And of course, you see potentiator, you see antivirulence factor that we have mentioned, and so not so many as compared to the others. So these are of course the bacteria targets. So a lot you can see is lung infection. So and respiratory tract infection, people with cystic fibrosis, with chronic infection, that of course causes a lot of resistant problem, and but also other infection as well, including C. difficile. As a gastroenterologist, I know there's a bit better, and we did some works on that as well, but also urinary tract infection and other infection as well. On the right, you can see the conventional antibiotic approaches, but also some of the newer targets. For example, LPX-C, that is the enzyme responsible for biosynthesis of lipid A, so it has been the target of newer directly acting small molecule of antibiotics that we are looking at. Vaccines, as I mentioned, is very important. As you remember from the slide, vaccines and antibodies are one of the most common antibiotic alternatives that people are developing. We mentioned this is important because it prevents the infection in the first place, and therefore reducing the need of total antibiotic use and therefore the resistance. And if we are able to target the bacteria or the microbes early, so this would be important to prevent the infection. So these, you can see that there are few in the pipelines that are of different phases, targeting different resistant bacteria and microbes as well. So I think this is one area that I think a lot is in development. And phage is, of course, another approach that is also common in the chart that you would see. So there are different approaches. There could be phage that are isolated from the environment, from the soil, or from different parts of the environment. So they could be natural phage. So we just isolate, we find the best candidate, and then we use it to target bacteria. It can be engineered. So of course, with genetic engineering, CRISPR, so we can modify the phage and to have better efficacy as well. And there are related products. So for example, endolysin are enzymes that degrade peptidoglycan of bacteria. So if we take these enzymes or engineer them, so that can be phage related products as well. So and then combination or some other approaches. So these are bacteria that have been targeting, focusing on the phage therapy. So some of the bacteria, Pseudomonas, that are important in terms of the resistance. If we look at phage therapy, of course, this is not new. We know that it is actually over a century since it has been developed. So, for example, Felix de Rally, not the one that discovered, but he really pushed for using this phage for bacteria. And we understand at that time we don't have good technology. So, actually, what he did was in a conditional medium, he looked at the turbidity that indicates the bacteria, and then he looks for these phage that kills the bacteria, and he filtered them out and used them directly on some patients. It was quite popular around that time, and has been used to treat infections, largely in the former Soviet Union and also Eastern Europe area, and also actually for a period of time it was quite popular at that time. But of course that fell out of favor, firstly because of the advent of chemical antibiotics that works well in the past before the resistance emerged, and also because of public geopolitical reasons as well. So that phage remains popular only in that part of the world. So the idea, of course, for phage is to infect the bacteria. So we can see that largely these phage belongs to the Caldaviridae family or order, and there are a few genus that are commonly used. So, for example, podovirus, saffron virus, and mild virus, and they would infect the bacteria in the litter phase. Then they burst bacteria to kill them. But of course, also when you look at the phage cycle, so it's important that we want to make sure that it is the lytic cycle that we are looking at, because if it is the lysogenic or temperate phage that can incorporate into the bacteria without killing the bacteria. So selection is important. We isolate, we assort from the environment, and also we want to select the most potent phage for them to be used. And also one thing is that for phage to be useful to kill the bacteria potently and also to prevent antiphage resistance, usually we need at least 5 to 10 phage to be used at the same time to be able to kill the bacteria fast. And so when they look at this pipeline, there are at least 30 companies. I think there are probably more developing phage for various applications, for Pseudomonas, for S. aureus, or E. coli. So this is the current landscape that we are looking at. We do have the excitement because of several success. This is one notable story that Dr. Tom Patterson, the professor of psychiatry at UCSD, he acquired resistant Staphylococcus pneumoniae from Egypt, and he was quite sick with necrotizing pancreatitis and septic shock. So his wife is an infectious disease epidemiologist, and also so they put together, they isolate the phage, and they did an intravenous injection of that, and actually he recovered. So it made the news. It was quite well known, and so people also partly get excited because of that. And subsequently, there were also clinical trials that has been done. So, for example, in wound infection in burns patient in urinary tract, using larger clinical trials, some in RCT, and I think the largest one is over 100 patients in intravesical phage administration in urinary tract infection, and some of them actually work well. Many of them works quite well. Some of them might be comparable to antibiotics, but and also they also observe quite safe profile as well. These are the pros and cons. The pros, of course, they are highly specific. Because usual phage target a few bacteria or even the strain, so they are quite specific. It causes no dysbiosis, at least to the entire bacterial population. Relatively minor side effects, apart from sometimes cytokine due to lysis of the bacteria, but compared to other therapies, relatively less or safe side effect profiles, and they are abundant phage in nature that we can harvest. Of course, there are cons. They are the other side of the story. They are a problem with antiphage